One of the really potent parts of our community is our medical students, residents, fellows, and it's represented by our resident fellowship committee. And we have some representatives of that committee here with us, and just want to bring them along. Alejandro, I don't know if you have your camera on. There we go. Perfect. And they're going to be presenting a topic for us. Thank you for being patient with us, guys. We're running a little bit behind, but we really appreciate it. And there's always some fun technical difficulties along the way when you're doing live streaming. Brittani, I think once you joined back on, we may have to share your slides one more time so I can get them on the screen. You guys are going to be talking about maximum local anesthetic dosing, and we're going to let you take that over right now. So welcome.
Thank you very much for the intro, Raj. And hello, world. My name is Dr. Brittani Bungart. I'm part of the RFC, as mentioned, and I'm here with Dr. Alejandro Hallo-Carrasco and also Dr. Alyssa Chen. We're very excited to be presenting this topic on behalf of the ASRA Resident and Fellow Committee. Go ahead, Alejandro.
Okay. Good morning, everyone, and thank you, Dr. Bungart, for your introduction. So before we dive into local anesthetic dosing, I'd like to briefly highlight the ASRA-PM Medicine Resident and Fellow Committee. The RFC is the trainee leadership arm of ASRA. We bring together residents, fellows, and medical students interested in the full spectrum of pain medicine. And we focus on education, mentorship, research, and national leaderships. So if you're a trainee or known a trainee who wants to get involved in the ASRA-PM Medicine mission, we'd love to have you join us. Applications are accepted year-round on rolling basis. And even if you are not applying, please come meet us at the upcoming ASRA-PM Medicine spring meeting in Arizona. Dr. Bungart is going to continue with the topic.
So why would we choose this topic for this short 15-minute presentation? And I think from a training level, this is something that we're tested on and also taught, at least in the United States, and I imagine across the world. From an international standpoint, though, speaking of the WHO, the World Health Organization essential medications list includes bupivacaine and lidocaine. So these are very important internationally. If you look at this diagram here, and you were actually able to zoom in and read it, you would notice that the backup to intralipid is ECMO. And so if you're in a resource-limited place in this country or other ones, knowing what you can give and how, where, and how much is very important, especially to make sure for patient safety. Go ahead, Dr. Chen, or Dr. Hallo.
Okay, so to start, we're going to talk about what are the maximum, like the different maximum local anesthetic doses that we can find in different popular references. So in this table, we summarize recommendation across 4 commonly used references: Miller, Barash, Up-to-Date, Open Evidence, NISORA, and also Open Anesthesia. And what becomes immediately clear is that while we often talk about a maximum dose as a fixed number, there is some meaningful variations depending on the source. So if we see bupivacaine, there is this one has a much tighter agreement across different sources, around 2.5 milligram per kilogram without epinephrine, and around 3 milligram per kilogram with epinephrine. This reflects that there is a shared recognition that bupivacaine has a relative narrow safety margin, and there is little tolerance for deviation. But ropivacaine, the story is a little different. Miller and Barash provides a range, while Up-to-Date often present a fixed conservative safety dose. Kind of shifting the teaching, moving away from theoretical upper limits towards a more toxicity-focused threshold. At the bottom of the slides are other two resources. NISORA emphasized that maximum dose tables from text have limited clinical utility by itself, but because the systemic absorption is going to vary depending on the blood type, injection type, technique, or different additives that we can use, meaning that a maximum dose is only meaningful when we are talking about a specific context, a specific nerve block or clinical context. Open anesthesia, that is also a popular source about between trainees, mirrors Up-to-Date and takes a similar conservative approach, emphasizing toxicity prevention rather than procedure-specific dosing. Dr. Alyssa is also going to continue with the rest.
Thank you. Yeah, so we see a lot of the variability that was mentioned in package inserts
It's
as
kind of
well.
hard to hear you, Dr. Chen.
Can you hear me at all? Okay, I'll just speak closer. Thank you. So we see a lot of the variability with package inserts as well. Looking at bupivacaine, we sampled the information from package inserts from 6 different countries across the world. We were limited by what we could access, though.
I'll
Through
notice,
the
sorry to interrupt, Dr. Chen, but I can't actually hear you. And I know others can. I know that I'm controlling the slides. So I may not be able to go forward.
I'll just raise my hand whenever you should. Oh,
Brittany, I can hear her. I'm not sure why her audio isn't coming to you, but I can advance her slides when necessary.
And I can hear you, Raj. Yeah.
Okay.
Thank you so much.
okay. Thank you. So for bupivacaine, we have 6 inserts found from different countries, but we were limited to what was accessed through an English search engine, Google. Next slide. So among the package inserts that reported a daily maximum, there's a consensus that the value is 400 milligrams in 24 hours. However, next slide. Aside from the daily maximum, USA reports on average higher maximum doses for use in specific contexts, such as field blocks and major nerve blocks, while Brazil has much lower maximums. Next slide. There's also variability in the maximum dosing for major nerve blocks for surgical anesthesia. Some inserts separated maximum doses based on type of nerve blocks, while others did not. Oops, sorry. There's also variability for ropivacaine, as we can see on the next slide. We were able to gather data from 5 packaged inserts from across the world, but again, the data was limited based on what was able to be accessed through an English search engine. Next slide. Among the package inserts that reported maximum field and peripheral nerve blocks for analgesia, there's consensus for 200 milligrams and 20 milligrams per hour, respectively. Next slide. There's also some consensus for maximum major nerve blocks for surgical anesthesia, with 4 of the 5 countries reporting 300 milligrams. Next slide. Interestingly, unlike bupivacaine, there's more variability to what is considered the maximum daily dose. And for bupivacaine, there is also a separate daily maximum reported for epidurals. Next slide. And finally, there's a lot of variability to what is considered maximum field block doses for surgical anesthesia, with only 2 out of the 5 countries reporting the same value. I'll hand it back to Dr. Bungart now.
Brittany, you're back up.
Perfect. Thank you so much, Dr. Gupta, for helping with the technical glitch. So it's great to be able to see these different additional recommendations from the package inserts. What do our local anesthetic dosing say from our expert guidelines? Well, if you look on the various societies, there's no current adult guidelines from ASRA to date, but what is recommended, especially from the last guidelines, is to always consider a minimum effective dose for your local anesthetic. There are pediatric dosing published through joint guidelines published by Dr. Suresh, though. And just briefly looking at that as a summary, besides at-risk children that are less than 2 years in age, this is what's reported as the recommended maximum dosing for single bolus blocks and continuous infusions. One thing you may notice is that 1.5 milligrams seems to be pretty low compared to what Dr. Hallo-Carrasco had mentioned, and also what Dr. Chen had mentioned. That's why Dr. Sweet, Boretsky, and Beard had actually done a letter to editor in reply to this to note that in practice, dosing, even in peds compared to adults, is also high. And here you can see in comparison the dosing where a single bolus is recommended at 3 milligrams per kilogram across all types, and continuous infusions between 0.4 to 0.5 milligrams per kilogram per hour. And this is for both ropivacaine and bupivacaine. There's a common clinical question that we think about too with max dosing, which is after you give a maximum dose, how much can you give and how soon? And based on this common clinical question that many of us encounter across the world, this prompted the work that myself and Dr. J and Dr. Fede Place have published in the last year. To assess this, we looked at the pharmacokinetic data and all the literature and extracted that, which is what a lot of the max dosing that Dr. Hallo-Carrasco had touched on are based on. And we looked at what some of the continuous and intermittent infusions that are highly dosed are done in practice. And those that we looked at were paravertebrals and TAP catheters. Of note, in these infusions, no cases of LASRA reported, but a caveat may be that that might not have been monitored or have been presented in that data. But we presume that there was no cases of LAST, and thus these intermittent bolus continuous infusions were of a safe dosing range. These are very complicated kind of graphs, so I just want to point out here a few things. This pharmacokinetic data based on the slowest eliminators, here are the solid red lines is the average of that data from the pharmacokinetic data. And you'll see then here also from the real world dosing for those intermittent bolus that the median for those infusions run just above and very close to the slowest eliminators of the people who may be more at risk for repeated dosing of local anesthetics at max dose. So these are complicated pictures. What about just boiling it down to a table? And so we did that for some rational redosing recommendations for pivocaine and bupivacaine based on this comparison between pharmacokinetics and real world dosing. And of note, this is based on healthy adults. We do have weight base in parentheses is for a 70 kilogram healthy person. This is based on ideal body weight. And the safe redose is based on the median slowest elimination or the pharmacokinetic data, while the danger threshold listed is based on the upper quartile of the average elimination. So maybe if you've got somebody healthier, you might be able to push the limits a little bit. Dosing presumes that there are no other sources of local anesthetics. So if your surgeons are also giving or another team, consider that in your dosing. Well, how does this compare then to what Dr. Sweet-Boretsky and Beard said? And actually the 1 hour dosing for the danger threshold kind of falls near to that. Always consider your at-risk populations and look at these references. Can there be an app for that? Yes. And a lot of the experts in this field actually recommend Johns Hopkins app, Safe Local, which includes epi, comorbidities, local anesthetic mixing, and remaining dose. The caveat here is a warning is if you put an extreme high weight up, that the doses are by total body weight. And as you can see here, I put in a very high weight for the calculation, and it said that I could give 125 milliliters of 0.5 bupi, which would not be recommended based on the package inserts. In conclusion, always think about that minimal effective dose, especially because, as you can see on the right, showing the pharmacokinetic variability in patients, even for Rupi and Bupi, there's no clear absolute answer, and it's patient dependent. So sorry to give you a board answer of it depends. The current LAST guidelines that are being joint between multiple societies are currently in process and will actually be including dosing for adults in the recommendations. Thank you very much for this opportunity to present this topic.
Thank you, guys. Wonderful presentation. It's actually quite a difficult topic because, as you mentioned, the pharmacokinetics are in the body are very different than the dose that you deliver in a syringe. So, Rakesh, any questions for our wonderful trainees? By the way, grace under pressure, when technical difficulties occur is a good sign of excellence and expertise. Well done, guys, managing and rolling with the punches.
Yeah, and first and foremost, I was texting Raj there that the future of the specialty is very bright. We have really great resident and fellowship committee members coming and presenting in the World Day, and that to an interesting topic. Brittani, I have been following your work on local anesthetic dosing along with whatever you published with Guy and Michael. Great work and good job.
Yeah. Well, Michael's watching. Hello, Michael, and thank you all very much. And everybody who's watching, if you have mentees, don't forget to nominate them for the RFC to join us. We are always looking for members to push the opportunities for the community.
Do you have any thoughts on all these local anesthetic dosing patterns being published mostly on long-acting local anesthetics and not so much on shorter-acting local anesthetics? What is your take on it? Like lidocaine infusions through fascial plane blocks and things like that.
Just to understand, you're asking about why there's more long-acting versus the shorter?
And if there is any guidance for shorter-acting local anesthetics.
I think you're touching on a point that's actually trending very soon based on Dr. Fetty Place's recent publications. We're actually seeing an increase cases of LAST and lidocaine uprising, whereas the longer ones we're getting, because there's been more and more data coming out on safe dosing, the serious LAST cases are going down, at least trending down from Michael's work. And I think that lidocaine infusions and the shorter acting ones are going to become more of a hotter topic in the literature.
Yeah, I've actually had more trouble with mepivacaine toxicity than I've had with bupi, ropi, or lidocaine ever in my career. Mepi dosing can get out of control really fast if you're not careful, and partly because it comes in higher concentration, and you start forgetting about the volume. You're used to larger volumes when we're doing peripheral nerve blocks, and then all of a sudden you've given more than you intended. So some of these you have to be really careful. So last question for you guys is, and this may be out of the scope of this conversation, is what about mixing of local anesthetics? How does that complicate the issue?
Dr. Chen or Dr. Hallo-Carrasco, do you want to give a shot, or I can also answer?
So from at least the books and literature that we use for teaching, the common consensus is that most of the doses that we use are not supposed to use when we are mixing different local anesthetics. So I think there is still more, we need more data about what is exactly the amount that we can give when we are mixing different types and different components in different nerve blocks. But at least most of the sources mention that we shouldn't use the maximum dose. So we still should try to use the minimum clinical dosing.
We also published a recent meta-analysis, like mixing short and long-acting local anesthetic did not give us sufficient advantage compared to long-acting only, at least for the upper limb blocks. There may be scenarios where mixology may help, but it only confuses calculations.
That's a good point. And the Johns Hopkins app that we recommend, it does take into account mixing, and it does it by a fractional reduction. So if you get 50% of one, you can get 50% of the other, is kind of like how it's currently recommended in the app.
And I think there's, not that I advocate this, but I think there's a really interesting video rolling around online of our good friend Jeff Gadsden at Duke doing some self-administered block experiments where he blocked himself, or had one of his people block him, doing some experiments with plain bupivacaine versus a mixed dose. Interesting video nonetheless, but very an N of one controlled experiment to demonstrate the impact that he saw. So anyway, thank you all for joining us, and I'm gonna reiterate Brittany's advocacy for the RFC. This is a fantastic committee within ASRA, and I highly recommend that if you're a trainee or you know trainees, med students, residents, fellows, come join the RFC. Be part of that conversation. This is our pool of people, like Rakesh said, this is our pool of people that people higher up are looking to kind of pull from for the next generation of activities that we're doing within the society and the community at large. So be part of that. I think it's a great, great group to be part of. Thank you, guys.
Thank you.
Glad we could be here today.